Renew.
Hello, Declan.
How are you?
I'm good. Just got back from Perth.
It was nice, wasn't it?
Crossed a few time zones.
Yeah.
It was lovely, though. Yeah, it was first time in 15 years that the USANS meeting has been out there in Perth. But we were treated to a few beautiful days.
So if you don't know the geography of Australia, it is a big country, as everyone knows. We're way over here on the east coast, Melbourne, Sydney, Brisbane, Adelaide, not so far, and way over on the west coast, like 3,000 or 4,000 kilometers away, 3 time zones away, is the beautiful little city of Perth. I think they describe it as the most isolated city in the world.
They're closer to Singapore than they are to Melbourne, and Singapore and Perth are the same time zone, and we're 3 hours ahead.
And you can fly directly from Perth to London, for example.
Yeah.
So we don't quite put enough petrol in the tanks of our airplanes here to get all the way to London. But so we're just back from the USANS ASM over in Perth. Well done to Shane and Trent and everybody at USANS for putting on a great meeting. And we did, of course, record a cracking podcast over there.
Yeah. Wait for the quackers, Rottnest Island, and of course all the sides of the meeting as well. Yeah. I think
but especially the
stick
quackers.
A bit of that in there,
So that will come in the next few days. Our conference highlights from USANS, which is very fun, and we caught up with some great guests. But actually, we stole one of the guests as well.
Yes, a lot of our visiting professors are medical oncologists and radiation oncologists. We have a great time with them, but we couldn't help it. Great urologist at this meeting, so we had to whisk him away.
And here he is, Steve Friedland from Cedars-Sinai, old friend of mine from years gone by, urologist. Welcome to GUcast.
Thanks so much for having me. It's exciting to be here.
It is, and great to have you back in Australia, I must say. As well.
It's been too long, way too long.
When was the last time you were out here, Steve?
So Declan and I were talking earlier about it. I think it was probably around 2015, somewhere around there.
Okay, so definitely due for a
because
visit.
actually we were talking, Alan Parton was here at the meeting. Yeah. And Alan, who's passed away now, unfortunately, former chair at Hopkins, one of my main mentors, was here at the meeting. And so catching up with him. So it was a while ago. It's probably a good 10 years.
Yeah. And you've had a busy few days. Do you have any plans to relax and see a little bit of the country before you leave?
A little bit. Flying off to Sydney this afternoon, and then working tomorrow in Sydney, and then actually have a day to play. And so I'm going to connect with Henry Wu, very good friend, someone I've known for a very long time, and hopefully have a very nice, relaxing day in Sydney.
Great. Well, look, while we have him here, we wanted to pick his brains on really an important topic of ours, a favorite topic of ours, and this is about biochemical recurrence in prostate cancer. And we've been dying to put this episode together.
Yeah, I was just going to say, this is a long-awaited episode. We've been waiting for the opportunity to get Steve in the studio, and it's so nice to have him in person.
It is, because we love these studio discussions. And this episode is brought to you with the support of our gold partners, Astellas, who are supporting Steve's visit out here this week, because he spoke at the conference as well. And they're also great supporters of GUcast. So thank you to everyone at Astellas. And the reason we want to talk about biochemical recurrence is predominantly based on a really fundamental change in practice for BCR that we are now experiencing with the advent of the data from a trial called EMBARK, which was Steve's trial published in the New England Journal of Medicine just less than 2 years ago, 2023, end of 2023,
October,
I think. Yeah, so it's still data that's kind of rippling out, and it's very, very important data. So we're going to come to that in a few moments later in the podcast. But what we want to do first, Steve, is go back a little bit in time, back 20 odd years. We were talking about it this morning when you were visiting us at Peter Mac, to this pivotal work that came out of Johns Hopkins 20 to 30 years ago, which defines the natural history of biochemical recurrence. And stick with us, audience, because some of you will be aware of this data. The Pound data became the Friedland data, but it's still just as important today, because when we are speaking to patients about biochemical recurrence, I still talk about this all the time, that there's a unique series from Premier US Medical Center from all those years ago that tells us so much about what is going to happen to me now that I've developed biochemical recurrence, because it's not necessarily panic, I'm in really big trouble, or I'm going to die from my cancer, etc., etc. So before we go and talk about this new contemporary management based on EMBARK, Steve, we thought we would ask you to take us back 20 plus years when you were at Hopkins to when that data was first published as the Pound data, and then revised by you in JAMA 20 years ago as Friedland et al.
Yeah, no, thanks so much. And it's great. We were actually at a tumor board together this morning, Declan, you and I, and actually we're talking about outcome recurrence, and it came up, doubling time. What is the long-term outcome of these patients? So still very relevant today. So in 1999, Charlie Pound, who was a resident at Hopkins, had worked with Pat Walsh, Alan Parton, and described really Pat Walsh's personal series. And Dr. Walsh had a philosophy that hormones have lots of side effects, which we know they do. And there was really no solid data that it improved survival. And so he was a big believer that hormonal therapy should wait until you have metastatic disease for these biochemical recurrent patients. And I think in hindsight, he was right more often than that was wrong. I think we have some data suggest in a subset that might not be right. But the beauty of it is these were patients who, by and large, they all had surgery, by and large had no radiation, which we could argue probably some of them should. And then they were watched until they had metastatic disease. And as I've talked about, when you take patients that you think have bad disease and we treat them aggressively and they have a good outcome, we all want to pat ourselves on the back that we made this huge difference. But maybe they didn't actually have as bad disease as we thought they did.
Yeah.
So you really do need a natural history study to tell us what are these patients going to do. And you can't do that now with PSMA imaging, metastasis-directed therapy. We now have EMBARK. We're never going to have that natural history ever again. It's a really unique patient population, unique period of time. So 1999, Charlie Pound, this is the Pound series in Hopkins, where we learned the median time from surgery to metastasis was 8 years, metastasis to death was 5 years. So I had the opportunity 5 years later come through Hopkins as a fellow, and they had just updated the database. And I worked with Alan Parton, and we ultimately published it again in JAMA. And there we found the natural history even longer, with some time. We had some better treatments for more advanced disease. And so the median time from surgery to recurrence was about 2 years, and recurrence to death was 16 years. Mm-hmm. So if you take a patient who had a bad outcome, develops a recurrence, metastatic disease, and dies from prostate cancer, on average, that's 18 years after surgery. That's a bad outcome for prostate cancer.
And that's long before all the modern treatments and imaging and all the fancy stuff for metastatic disease.
We had no PSMA, we had no enzalutamide, abiraterone. I mean, by the time we were published, docetaxel wasn't even approved until the very end of that study period. So the world has changed dramatically.
So Steve, just to clarify, so in this series that you looked at where the time to recurrence after surgery, the median time is 2 years, these are in the high-risk patients,
So
correct?
these were all comers.
All comers, right?
All comers.
Yeah.
And so then what we did is said, well, this is great. This is pretty good outcome.
Yeah.
But when you look at the Kaplan-Meier curves, you do see some deaths within 1, 2, 3 years. So the question is, who are those people? Because those are where just watching them, what was done is probably not the right answer. Mm-hmm. And so we looked at different risk factors. And ultimately, there were 3 risk factors: high-grade disease, Gleason 8 or higher, grade group 4 or 5, early recurrence within 3 years versus later. But the real key driver was the PSA doubling time. And that was the thing. And if you go back to the Pound series, they only had a small number of patients who had PSA doubling time data. So it's very interesting. They actually took the middle point of their patients, which was 10 months, and said you're either low, short doubling time under 10, or you're long above 10 months. That's for the 10 months that has been perpetuated
in every trial.
Still here today. Wow.
From the median of their patient population.
Amazing.
Never did fancy statistics to look, is that the right cut point? So when we came along, we had 379 patients that had doubling time data. So we actually divided them into every 3-month group: less than 3, 3 to 6, 6 to 9, 9 to 12, etc. And then in a very not AI-driven fancy way, I started looking at these, and some of these groups look pretty similar. That we said, all right, these 2 groups look pretty similar, these groups look similar, and ultimately came up with the less than 3 months, which D'Amico had shown as well, and others, really aggressive. 3 to 9, pretty darn aggressive. But 9 to 15, not so aggressive, and above 15 months, really, really excellent outcomes with observation. So that's how we came up a little bit more scientific, but I mean, doubling time is a continuous variable. Is 9.1 months that different than 8.9 months? No, but at some point you got to draw a line somewhere.
Yeah.
Still,
Wow,
Renew,
how interesting.
isn't it still? It's so nice to hear of something 20 or 30 years old that anyone can have. Everyone's got PSA tests after their prostatectomy. We don't have to do fancy imaging or some sort of genomic this, that, the other. You just have to do a few PSA tests for these patients with biochemical recurrence. And based on that data from 20 or 30 years ago, you can say, this is your risk of developing metastases. And it's very reassuring.
Yeah, so maybe this is a good time to bring up the ultrasensitive PSA results because, Steve, so we have ultrasensitive PSAs and it does cause patients, some doctors, a lot of anxiety, watching their PSA go from 0.01 to 0.03 to 0.04, then sometimes back down to 0.01. So when you're talking about these doubling times, what kind of levels of PSA are we talking about? Does it matter in this ultrasensitive range?
Yeah. So if we go back, it's a great question. If we go back to the actual Hopkins data, we go back to the Pound, we go back to our series, it used conventional PSAs, if you will, so not ultrasensitive, 1 decimal place, and really interestingly started the clock at 0.2 and then calculated going forward. So anything below 0.2 didn't get computed in that PSA doubling time.
Right.
So now we've done some analysis since then with a different data set using some data from patients treated within the VA system and using ultrasensitive. How accurate is ultrasensitive PSA doubling time? And what we have found is if you have a very long ultrasensitive PSA doubling time, the patient goes 0.1, 0.3, 0.2, and like taking forever, that predicts really, really good long real doubling times. So we can identify those more indolent cases pretty early. But the patients whose PSAs goes up relatively quickly don't always continue with a super real quick doubling time. And that's where, to me, I do like the ultrasensitive. It does create more anxiety. As we know, PSA stands for patient-specific anxiety, right? We know that for sure. But I like to know because otherwise you have undetectable, 0.1. I'm like, whoa, is this like, where did this come from?
Yeah.
Where if it's 0.1, 0.2, 0.5, 0.0, 0.02, 0.05, 0.09, I have some warning that we're coming.
Yeah.
We can start the discussions. I can start to mentally map out what is their doubling time, how aggressive are we going to be. Whereas all of a sudden, when it comes 0.1 from undetectable, that's scary.
Yeah.
Right. So I do like it. It creates more work. I'm a numbers guy. So I like the numbers, the statistics. We can calculate things.
Well, I mean, that's one way to justify that because, I mean, it does seem that the longer a patient spends in that ultra-sensitive range, the better their long-term outcome.
I suppose it's particularly helpful for those patients who might eventually reach a threshold of 0.2. Do you still consider 0.2 to be this is the AUA guideline definition of BCR, isn't it?
Yeah,
or there or thereabouts.
I think you said it well. There or thereabouts. Okay. I mean, obviously, I know we're going to get into this. PSMA imaging has changed everything, right? Yeah. So even a 0.1, you do a PSMA PET scan, and a fair number of those patients will have something. So ultimately, when you're writing papers, when you're doing trials, you need hard endpoints. The real world is a little softer, a little squishier. And so the question is, at what level am I going to do something? Start imaging, doing salvage radiation. For me, it's often below 0.2.
Yeah.
Okay. But rising, I know we're on track to reach 0.2. Yeah. The one who's 0.04 and has been 0.04 for years, it's a few benign glands left behind. Leave them alone.
It's really the kinetics rather than absolute values.
Yeah.
So having established, and that's a really important message for all of us and for the audience, that the single most important thing you can be doing with biochemical recurrence early on is do regular PSA tests and figure out, is my patient in the less than up to 3 months? So they're doubling really quickly, doubling time less than 3 months. Yeah. You showed there's these classic graphs from the Friedland paper 20 years ago showing the Kaplan-Meier
6 years median survival.
6 years median survival for those patients.
Not 16, but 6.
So if you're doubling every 3 months, right, this is a patient
that's bad.
Emerging system. 3 to 9 months, this is still kind of a call to action for sure, isn't it? And above 9 months, maybe de-escalate. Now, before we go on and talk about EMBARK, which is a particularly high-risk BCR population, that needs systemic treatment. So the EMBARK population is about patients who, need to be on ADT traditionally or now ADT plus something else or something else entirely. But between the ones with the slow doubling time and the EMBARK population is like, I suppose, the salvage radiotherapy population, Steve. It's the classic BCR, EAU have come up with some risk stratification within it for low and high risk, maybe de-escalation. But can you tell us a bit about your approach to the BCR patient before they're at the embark stage? The ones that, okay, how are we going to consider you? You know, how should we advise you about the role of post-operative radiotherapy, or what sort of imaging should we do?
Yeah. So, I mean, I think in today's world, you know, you're going to want to risk stratify. And, you know, same with a patient newly diagnosed. We don't treat microfocus Gleason 6 with a PSA of 5, the same as every core Gleason 8, PSA of 50. Those are completely different patients. Yeah. And we have the same analogies in BCR. The doubling time less than 3 months, the guy who's 0.03, 0.04, 0.05, you know, the challenge is a lot of patients in the middle, right? Yeah. So how do we do that? So I do think getting imaging, staging, understanding what we are, PSMA has obviously been a game changer in terms of that. And I'm a big fan of the salvage radiation because it really is a second chance at cure. And, you know, we look at some of these guys with a longer doubling time and we say, do they really need cure? You could argue not necessarily, but every now and then there's one who's looking indolent and something happens to them over the course of 5, 10, 15 years. Side effects, for the most part, can be pretty tolerable of salvage radiation. You know, there's certainly side effects. So I'm a big fan of that. And, you know, certainly post-surgery, post-radiation, understanding what the treatment options, it's less clear cut. We do have some salvage options, right? Salvage prostatectomy, re-radiating, HIFU. So it's not, there's nothing, it's just less clear what that should be. But I'm a big fan at doing that. And, you know, in the old days, pre-PSMA, biochemical recurrence, low PSAs, we radiate 80% of the time, the PSA would go down. And you radiated the prostate bed, maybe plus minus nodes. And half the time it stayed down to undetectable if you got it early enough. Yeah. So, you know, systemic therapy has clearly changed the game, and we're going to get obviously into that discussion, but we can't forget the salvage local therapies, which really can be a second chance at cure for some of these patients.
Yeah, I think that's a really important point. And I think in the era of PSMA PET, we've perhaps gone backwards a little bit in the utilization of salvage radiotherapy. You know,
correct.
Patients often use PSMA PET as a reassurance that this is okay, we don't need to treat this biochemical recurrence, when that would have been the window to perhaps to salvage them.
Correct. And that's been my concern is, you know, PSMA I think is great, but I worry about the PSMA negative patient and we're like, oh, there's nothing to radiate. We're just going to wait. Yeah. And we're going to continue to wait, and we're going to continue to wait, and we're going to continue to wait. And now your PSA, as we had a patient this morning, is 35, and his PSMA is negative. And it's like, what are we going to do? Yeah. You know, I think we do miss that window simply relying only on PSMA.
Yeah. Well, that's a great intro to exactly that. So we had a few patients on the tumor board MDT at Peter Mac this morning in that situation. These are now high-risk BCR by EMBARK, the trial that we have Steve here to talk about today. And congratulations to you and
huge
all your co-investigators around the world, Neil Shore and Australian investigators.
Many people, absolutely, huge team.
For those who have no idea about this, and I've flagged it already, like this is very, very important for urologists and radiation oncologists who deal with BCR to be aware of this this trial and the impact, because now enzalutamide, which we're very experienced with for metastatic prostate cancer and CRPC and so on, now has a role earlier in this hormone-sensitive BCR setting. So tell us a bit about EMBARK. Tell us a bit about the trial. I mean, we've kind of established why it's going to be an important trial for these very high-risk, fast doubling time patients. But tell us a bit about it and the findings you had.
So really, it's a simple question. It's patients with high-risk biochemical recurrence, and the label is however you want to define it. In the trial, it was doubling time less than 9 months, PSA greater than 1 post-surgery. So we're not competing with salvage radiation. Should have been done if they're a candidate, or nadir plus 2 post-radiation. So a little bit farther advanced in terms of the PSAs, short doubling times. And as you had mentioned, Declan, I mean, historically, we gave these patients ADT. So the question is, can we give them better ADT and improve their outcomes? And so one option, one arm of the trial was adding enzalutamide to ADT, which to me is just better ADT. That's how I think ADT should be. If you're going to give someone ADT and all these side effects, why not do it right? Right. So that was what we were asking. And then actually the audacious question here is, do we even need the castration anymore? Yeah. Do you even need the ADT? Can you just give enzalutamide by itself? Is it so potent we don't even need the castration anymore? Yeah. So it's 3 arms, and the primary outcome was metastasis or death. It's bad things. We want to keep our patients alive with no metastases. So that's the question, is can we keep them in that disease state as long as possible? And there was some interesting nuances. If patients at around 9 months, PSA was less than 0.2, we stopped treatment. And once the PSA rose to certain thresholds, they would go back onto their originally assigned treatment. So it gets a little complicated, 3 arms, treatment suspension, retreatment. But it's can we give better ADT to improve outcomes for our patients? It's a fundamental, simple question.
So before we dive into it, just remind us of the patient population. For those of us who look after quite a lot of BCR, just to position these patients in my head, Steve, having said they're not the ones for salvage things. So just remind us of the inclusion criteria, because it goes back to what you just told us at the start about the BCR risk based on the original Hopkins data, doesn't it?
Absolutely. So doubling time less than 9 months. That was the key criteria. PSA is greater than 1 post-surgery, nadir +2 post-radiation, not candidates for salvage local therapies, and conventional imaging negative. This term that I'm trying to throw out there, CIN, prostate cancer, conventional imaging negative. And, there's some testosterone and they couldn't have recent hormones and some other criteria, medically fit, different things. But those were the key cancer criteria.
So this didn't include patients who'd had a radical prostatectomy, had salvage radiation, and then had recurrence.
No,
or
that is, yeah.
Okay, so
if we actually look at the patient population, 50% of the patients, give or take, had surgery and salvage radiation.
Yeah.
A quarter had just had surgery and were deemed not candidates for salvage radiation. We didn't capture why, but the doctor that said they're not a candidate for whatever reason. And a quarter had just radiation, primary radiation, with really no salvage therapy.
Yep. Very good. Yeah.
So what did you find? You got this 3-arm study. The patients come in, the PSA is 2 or 3 or 4. It's doubling quickly. They have no metastases, but we know from the original Hopkins data, they're going to get metastases. So
Correct.
We would normally be putting them on ADT because the PSA is going so quickly. Maybe even intermittent ADT, some of these patients.
Yeah.
But now a third of them were going to get ADT plus ENZA. And the really interesting group just get ENZA on its own. And then in all 3 arms, if the PSA went right down less than 0.2, they're going to have a stop.
Yeah.
So what did you find from the primary endpoint of these 3 arms?
It works.
It works.
And it works really well. So adding enzalutamide to ADT cut the risk of metastasis or death by 58%. Really, really dramatic improvements.
Yeah.
And amazingly, enzalutamide by itself, without castration, cut the risk of metastasis or death by 37%. So not quite as good as the combination, but there's some quality of life benefits to monotherapy, better preserved sexual activity, less hot flashes, different things. So I think it has a role to play for sure, but really, really dramatic improvements in metastasis or death, which is a surrogate endpoint for overall survival. We're actually seeing trends in favor of overall survival. We're waiting for updated data, but I'm really excited. If you look at the combination arm, the hazard ratio for overall survival, it's immature, p-value of 0.01, but didn't reach significance by our definition, but hazard ratio is 0.59 for overall survival, 41% reduction in the risk of death. If that holds, to my knowledge, and you guys have seen a lot more than I have, but to my knowledge, I don't think I've ever seen a prostate cancer agent with a drug for systemic disease with a hazard ratio for overall survival in the 0.5s.
Yeah.
We've seen a lot of low 0.6s. I don't think I've ever seen a phase 3.5. So that holds, beats anything else. It really is a game changer.
Wow. And what about those patients on the intermittent treatment arm?
So they all, if they had a good response, they all got treatment suspension.
Yeah.
So it wasn't a separate arm that's treatment suspension. So if we look, it's interesting, about 7% of patients in all 3 arms dropped out within 36 weeks. So equal across all 3 arms.
Yeah.
So of the people that made it to week 36, almost everybody in the combination arm got less than 0.2. Actually, only 9 patients out of over 350 did not get treatment suspension combination. Less than 3% did not get treatment suspension. And in the monotherapy arm, similarly, vast majority of patients. Whereas with ADT alone, a third of patients never natered.
Wow.
So they're now castrated for life because we didn't add enzalutamide.
Wow.
So it's kind of almost a no-brainer that ADT on its own for these patients is now below standard of care with that type of MFS and stuff. And the question is, well, of the two intervention arms, adding the ENZA to the ADT, which we're very experienced with MHSPC or even in the CRPC era, or ENZA on its own, which we are inexperienced with. And although you've said the hazard ratio is not as strong, it might be attractive for some people who don't want to be on ADT. We have all too much experience of patients being very miserable, especially younger patients on ADT. So can you tell us a bit about what it's like then for these patients on ENZA monotherapy from a quality of life point of view, or different side effects to having the ADT on board as well? And is that going to be one of the real options for our patients in the future, to look at it and say, okay, well, maybe the hazard rate is still way better than ADT on its own, and maybe the trade-off of avoiding the ADT will be worthwhile. So what does that arm look like? Because I have no experience of enzalutamide or any ARPI monotherapy.
Yeah, no, I think it's interesting. I mean, I think, as you say, we in the past, we gave everyone ADT, and you had a debate who needed something added to ADT. I think for this high-risk biochemical occurrence, the answer is everyone needs enzalutamide. And then who do we add ADT to the enzalutamide? Yeah. It's a different way of thinking about it.
Different way, totally different.
Enzalutamide, yes. ADT plus minus.
Yeah.
So, in terms of the monotherapy, I mean, you see a lot less hot flashes. Remember, they have normal testosterone levels. The testosterone tells the brain, you got hormones, you don't need to have hot flashes. We do see that testosterone gets aromatized to estrogen. And so it's going to drive breast growth, 45% gynecomastia, 15% nipple pain. So you radiating the breasts, the multidisciplinary care, right? Bring in the radiation oncologist, radiate the breasts before you start the monotherapy. Very, very important. So you're killing off the breast buds before they get enlarged, because once they're enlarged, radiation is not going to work. So it needs to be done beforehand. Tamoxifen can also work, 10 to 20 milligrams. Literature would say every day. Some anecdotal experience that even every other day may be as equally as effective, maybe reduce some of those side effects of the tamoxifen. Anecdotally, first off, trial data. We'll always start with the trial data and then we go to anecdotes, right? So if we look at the trial data, in terms of the quality of life, we had patients fill out questionnaires every 12 weeks. We can't really see a big difference in terms of quality of life, except better preserved sexual activity, which is really important for our patients. Sure. And what's interesting, so you look, so median age of 70 in EMBARK trial, all had, again, half had surgery and radiation, the other half had surgery or radiation. So they had some treatment to the pelvis that can certainly impact sexual activity, right? But 60% of patients were still interested in sex at baseline, 40% were still active. I'm really intrigued by the 20% that are interested and not active in terms of libido, and what does that mean, and how does that affect quality of life? And I could if I wanted to, or maybe just don't have the partner, or my anatomy doesn't allow me, but I'm still motivated. It's interesting, and that's, to me, one of the key strengths of the monotherapy is to better preserve that. Anecdotally, I'm hearing a lot that patients tolerate it much better, but when we look at our questionnaires, we don't see that. I think our questionnaires are too coarse. They're not granular enough. There's other studies that have looked at the impact of different agents. It's amazing how much you can give patients and still preserve their quality of life. So I'm not sure we have the right questionnaires. I think there's a problem in the field, not an EMBARK issue. I think it's a field issue that we need better ways to capture the quality of life for our patients. And maybe it's Fitbit and activity measures and different things. I don't know. But it seems like they're tolerating the monotherapy much better, just anecdotally from what I'm hearing and seeing.
I mean, such a great trial for so many reasons, but I think that some of the key messages, of course, the stamping of doublet therapy is really the standard of care, and not just that, but stamping of ADT alone as just inferior care. And, we've often wondered about this, and we've seen how, we've seen the activity in the NMC-RPC population, the metastatic hormone sensitive population, and now this. So that in itself is very clear. And then
and I agree. And I mean, to me, the next final frontier is the radiation patients. That's the other place we use ADT. We're waiting on some trial data coming up maybe over the next year or so. But to me, I mean, I think the future is if you give ADT, do it right. Either add the RP to it, an androgen receptor pathway inhibitor like enzalutamide, or do the enzalutamide by itself. And there's trials looking at other RPs, monotherapy. But to me, that's would be the answer. In general, we need to move away, just in general in prostate cancer, from ADT alone. It's just not good enough.
I think patients would say hooray to that as well. We speak to patients a lot about this. We've had a number of podcasts about this. And, you know, I think, so what's your take on it then in contemporary practice today? If you have a patient with high-risk BCR, the EMBARK population, like the one we spoke about this morning, who had a very significant cardiac history, for example, as well, is it that you have to figure out about the interest in sexual function to push you towards the enza monotherapy? Or even if someone is not sexually active and that's not a high priority, do you think the enza monotherapy has a role for those patients, or should we just go for the doublet because the hazard ratio is a bit better?
Yeah.
The trade-off.
And that's where, I think the challenge comes if you look at the trial data itself, sexual activity is really the motivating driver, I think, for the monotherapy. That's what we see from the EMBARK trial. If you talk to people who have a lot of experience with monotherapy, Neil Shore, Bertrand Tombal, others, they will just tell you the patients just tolerate it much better. Again, we didn't capture that in the trial. So, but that's the sense I hear from a lot of different people. And because it's approved in the US by the FDA, covered by insurance, you have two groups of providers that I've seen. One is, I'm a little skeptical about this, hazard ratio not quite good, I'm not going to do it. And others are like, want to be the early adopters. And like, this is really interesting. I want to get some experience with it. And when you talk to those people that are doing it, they're really big fans because patients, again, anecdotally, it's anecdotes, it's not the trial data. Patients are really tolerating it a lot better. So I do think in time it will have a role beyond just preserving sexual activity better, but that's what I can tell you based upon trial data today.
And did you look at PSA kinetics in response to treatment? And did people who achieve very quick declines of their PSA into that 0.2, less than 0.2 level, did they do better?
So we have looked at that. We do see the vast majority respond really quickly. We haven't necessarily looked at the time course as a prognostic factor, but what we do see, interestingly, is that when you get treatment suspension, and PSA for many of those people ultimately does go back up, and you go back on treatment, we looked at, do you renator at less than 0.2? And again, with the enzalutamide arms, the answer is very commonly. With ADT, a quarter of those patients that had the good response initially don't nadir to undetectable again. So at each step of the game, we're seeing that ADT is inferior. We haven't necessarily looked at how quickly you get down to less than 0.2 as a prognostic factor.
Yeah. So I guess, Steve, the main question in my mind is how do we put these results in the context of the real world when PSMA PET now is just done as a knee-jerk reaction in these patients?
Particularly here in Australia.
Right, exactly. So what do we do? I mean, how do we design that trial?
So, I mean, I think that's the challenge, you know, and so with PSM, so there was a recent study that came out that looked at EMBARK-like patients that met the PSA criteria, conventional imaging negative, PSA doubling time, and did PSMA PET scans on them. And about 85% of those were PSMA positive.
Yeah.
And of that, about half of them were distant metastatic disease, half were local/regional nodal disease. So I think, you know, keep in mind, EMBARK answers the question how to do systemic therapy. It doesn't answer when to do systemic therapy. And that's very important. And this really is post-salvage radiation. So if you're seeing stuff on PSMA and you can radiate that, you should be doing that. And I think that the question comes in is you've maximized your salvage radiation therapy. Okay. You've done that. You've hit all the nodes. And now you're starting to see some bone mets. And the question is, for the short PSA doubling time patients, do we do EMBARK? Because there's nothing more local therapy we can do, right? So they would have met EMBARK criteria. Do we do EMBARK, i.e. enzalutamide? Do we do metastasis-directed therapy? or do we do both?
Yeah.
And what I would say is for that patient, short doubling time, not the long indolent patient. I think metastasis-directed therapy is great for that. STOMP, ORIOL,
Yeah.
we have a lot of data. For the short doubling time, when you look at the data, you could say EMBARK says, based on that, I know enzalutamide has benefits.
Yeah.
If we look at the radiation trials, I'm guessing we're all believers here to varying degrees. You can say, I believe, I think this has benefits. So why would I give up something I know works in favor of something I think works? So to me, the answer is enzalutamide, yes, and metastasis-directed therapy if feasible. And hopefully we get even greater less than 0.2 at the 9-month. Because now I'm not committing the person to lifelong hormones.
Yeah.
It's not the true metastatic ARCHES, population, Enzamed, et cetera, Titan, where they need lifelong treatment. It's 9 months.
Yeah.
And I'm hoping they can more likely get off and stay off longer. And patients with 9 months with appropriate cardiac evaluations, things can tolerate hormones pretty well for 9 months.
Yeah.
So, Renu, what do you think? This is very important for the audience for this podcast, who very many of whom are urologists or radiation oncologists, that number one is recognized now that this is an amazing option for our BCR patients with those fast rising PSAs. And it's all about the timing of systemic treatment, because now they should be intensified with Enza on its own, or just with Enza combined with ADT, or Enza on its own. And as you listen to this around the world, it is becoming, receiving regulatory approval all over the place. It's already approved in the US. It's just been approved.
EMA April last year.
April last year.
So
And here in Australia, regulatory approval. We don't have reimbursement yet. Hopefully that will come. But my question to you, Renu, is we're always banging on this podcast about, urologists and radiation oncologists learning to use ARPIs themselves, if not referring on. And this is a pure urology, radiation oncology population. So can this be managed within the urology population, or do we need to refer to?
I think it needs to be managed.
It needs to be managed
in the urology population. I think that's the key message here.
I think so.
This data tells us we need to get familiar with these drugs.
But some of the youngsters out there who are not used to doing ADT and adding in some bicalutamide mightn't be as familiar as Steve. So how do you think this fits into the new urology landscape with trainees who maybe have been seeding the metastatic patients to geometox? Not that that's a bad thing, but these patients don't have metastases, and this is just hormone therapy.
Correct. And so, there was a reason EMBARK was initially presented at the AUA. A urology meeting.
Yeah.
There was a reason. That was very strategic, right? Yep. There's a lot of discussion that went into that. And, maybe you get more press if you're at ASCO or something. It was a very strategic decision to present it at a urology meeting. We had a USAN session you talked about a couple of days ago. Joe
Ischia.
It was great. And ultimately, his comment, I think, was very, to me, it rang true, is it really should be managed by the smartest person in the room. The person who can manage it and know what to do with it. And I think that should be a urologist, right? This is something we're very capable with. But if you're not comfortable as a urologist, now we're aware of this data, you need to get it in the hands of someone who can. That's the right thing for the patient, right? It's always what's most important is what's best for the patient. But that could be referring to another urologist, right?
Absolutely.
They could send them to you guys and you can manage
exactly
it.
Right.
If they can't, that's fine. But I do think this is a urological drug. It's a urological space. And Declan, you and I were talking earlier, it worries me that urologists are becoming proceduralists. And we're so focused on the surgery and the biopsy, and we've forgotten managing prostate cancer and the biology and understanding these things. And as we think about right now, we're hitting AR, we're hitting it early, we're hitting it hard, and we're seeing amazing outcomes. We still see patients developing metastatic disease, still dying despite this. We need to think beyond AR. There's going to be new drugs, new biologies. Urologists need to be a part of this conversation and be involved in managing these patients, not just the surgical side.
And especially when it comes to hormonal therapy, because traditionally urologists have been very good at managing ADT. We've looked after patients from diagnosis to death in the olden times, and things have sort of changed a little bit, but it is important to bring it back. And I think the real tragedy would be a urologist managing this type of patient with ADT alone.
Correct.
I think that is clear.
That's what should not happen.
That's what should not happen.
Or a medical oncologist who's not aware of the data.
Exactly.
Either way.
But the who's the smartest person in the room thing, though, you know, that everyone out there is listening.
I like that comment by
who is
Joseph
smarter
Ischia,
than you?
because most urologists will go, well, obviously it's us. So we need to be able to manage.
Of course, if the room is only full of urologists. But what about in the MDT this morning at Peter Mac? There's lots of very smart people in that room.
Very smart
Who
people.
are the smartest people in the room? Some of those nurses in there.
Yeah.
The bloody nuke med physicians, they certainly think they're the smartest person in the room.
Yeah.
But anyway, the point being, look, on this podcast, it's been fantastic to have Steve in here talking about right back to the start of understanding BCR and identifying the at-risk patient, segueing through the role of radiation and imaging. But really, I'm so impressed with the EMBARC study, Steve. It's
Yeah.
been a fantastic advance for patients in this experience. And you can only just imagine what it would be like if you stuck EMBARC into the Hopkins population from 20, 25 years ago. You know, those patients would be living into their hundreds, really, wouldn't they? So it's a
Correct.
great advance, and congratulations to you and all your collaborators for this great...
Really practice-changing data, and it's very impressive. So doublet therapy, or if you're going to do a single therapy, make it enzalutamide rather than ADT.
on its own.
Correct.
Great. So that's all we have time for on this episode of GUcast. Steve is wandering up to Sydney, I think, tonight, and then Singapore tomorrow, and we'll see you at the AUA in a few weeks' time.
Yeah.
Absolutely.
And we'll be back with our USANS episode
Oh,
in a
yes,
few
the
days'
youth
time.
conference highlights, yep.
Exactly. That's just with the editors
coming.
at the moment. Thank you very much to our friends at Astellas again for supporting Steve to be down here this week, educating us, and for being gold partners of GUcast. We'll be back again very soon.
See you soon.